Hey guys, welcome back. In this instalment, we're going to be looking at which therapeutic exercises work for tendinopathy, and we're going to try and consider why that might be the case. It's my belief that if we start to consider the why, we can start to improve our therapy and get better outcomes for our patients. So that's one of the big things that we're really trying to do is actually get a better understanding of what we should be doing with our patients and how we can expedite our outcomes and get much better clinical benefit for our patients, which is hopefully something we all want to be doing. So we know loading works. There's some very good evidence on that, despite occasionally people trying to argue there isn't. The evidence is pretty robust that loading works for tendinopathy, but where there is a lack is identifying what is optimum. And I should probably point out at this stage, there will never be that data. It will not exist. What is optimum will be very individual. It will depend on the person you've got in front of you and what is going on with them. So I actually think we should stop trying to search for an optimum. We should start trying to determine what good rehabilitation should look like, what it should include, and how we can try and progress and what markers we should use. But that then needs to be tailored to the individual that's in front of you. The first bit that comes out from the majority of the literature is that activity modification is important. So tendinopathy, as we've already discussed, is a load-induced pathology, whether that is underloading or overloading that has led to those changes in the tendon. And as such, what we want to do when somebody has a symptomatic tendon is to start to control the stress through the tendon in order that we can get symptom control. And once we've got symptom control, we can start to step the person up to reach our sort of target of what their function should be like. And it's this symptom control that's important across all musculoskeletal conditions. It's what comes out for low back pain, acute low back pain, with the likelihood of developing persistent low back pain. And I think it's probably true with tendons that if a person can get good symptom control, they can understand why they're getting a flare when they have a flare, then they can self-manage and do extremely well. If they can't understand and can't get control of their symptoms, they are literally just going to go through boom-bust cycles or spiral. So they do more, they get worse. Because they got worse, they rest. They're doing less. That actually degrades them even more, and they're just doing worse and worse and worse. And you'll see this in many of your patients. They've either gone through this spiral and worsened, or they've gone through repeated boom-bust cycles where they do a lot, flare up, do less, but often that's gradually dropping as well. So as a key part of trying to prevent that is to use this sort of pain monitoring model, which has been popularized by Karen Silbernagel, to identify what is an appropriate level of symptoms. Now, the numbers don't matter, okay? But we use this to try and give a patient a ballpark of, well, okay, look, if you've done sort of a 30-minute walk and you're now sore as a consequence, how sore is it? Is that appropriate for the length of time you spent exercising? If it is, then they may say, actually, you know, I'm happy with that, even if they deemed it a 4. But if they're starting to find those symptoms are actually quite severe, they're limping, they're struggling to move around, and they may grade that then as a sort of 6 or a 7, well, that is then at the level we probably just want to pull their exercise down a little bit in order to help them settle so they can get control of their symptoms. And as part of controlling the overall load, we can consider a variety of elements within that. So we can consider the volume, the intensity, frequency and duration of the activities. Where we have challenges are patients where we might struggle to actually modify the load. So patients with high BMIs who do very little activity, it's a big challenge to reduce their stress through their gluteal tendon or their Achilles tendon in order to get some symptom modification. And occasionally this is where we might look at a biomechanical alteration of putting in a heel raise to lift the foot up to reduce the stress through the tendon. Or we may use the same sort of modification for tibialis posterior tendon disorders, so PTTD, so posterior tibial tendon disorders. It's got all sorts of names for tib post dysfunctions. Whichever one you want to use is fine by me, but we might look at using orthotics via a podiatrist in order to reduce the biomechanical stress through the foot and the tendon, and that can work well as well. So I would encourage you to educate patients about this model, and this is actually the slide I use with my patients to help them comprehend how to get a balance in their stress through their tissue. Now, if the problem then is an insertional tendon disorder, gluteal tendon, tib post, peronei tendons, insertional Achilles, we can consider reducing the compression through the tendon. With patella tendons, that was the one that I sort of pulled back. With patella tendons, compression may be part of it. There's been some recent anatomical work that's shown that there are different anatomical shapes to the inferior pole of the patella that may be part and parcel of why we see sort of inferior pole disorders. But we're not convinced at this moment about that exact role of compression for those. But for all other tendons, what we seem to see is this type of pattern, and in this case this is the Achilles, with a foot being dorsiflexed. And I thank Peter Gettins for providing this slide as well. So what we can see at this sort of level on the image, just here if I can draw it, is the bursa. The bursa's moving as the calcaneum migrates into the Achilles tendon as this person's foot is passively dorsiflexed. And this is where we see tendon change occur, sort of around about here. So we'd often observe that that zone of the tendon, because of this calcaneal compression, has started to become more disorganized over a period of time, and the tendon has undergone the typical sort of hallmarks of tendinopathic change that we observe. So if the person has a high SIM factor with an insertional disorder like GTPS, tib post, peronei, and insertional Achilles, reducing the compression through that area can be useful. How we do that for the gluteal tendons would be to reduce sort of the typical sort of standing on one leg type pose that many people will use whilst they're stood around waiting for buses and the like. We may try and reduce the valgus angle at the knee, or the sort of foot pronated position that they often will adopt and stand in, because all of those will have an impact on hip adduction, which may reduce the stress on the gluteal medius and minimus tendons. So they're worth considering. And when we then come to exact interventions that have been looked at and been proven to work, we have the LEAP trial, which has shown a good outcome with a progressive loading approach, isolating stress to glute med and min, and it's very much useful for you guys to go and have a read of this and look at the project. But by no means do I think those exercises are the only ones we could utilize. The study in its own right showed a very good outcome when exercise and education was compared with corticosteroid injection versus wait and see. You can see the outcomes as we go down here. So this was a publication in the British Medical Journal, as you can observe here. And it's the best data we have at the moment for GTPS. And it does show the importance of exercise. So that was the LEAP trial. Very good, sort of good strategy of progressive load. Interestingly, at the same time, a study came out called the GLOBE trial, and showed that graduated loading was only equal to sham exercise. The sham exercise being this group of exercises here that was deemed to not load the tendon. Now, interestingly for me, anyway, looking at this, is I'm not convinced these exercises down here are all that bigger or gooder way of loading the gluteal minimus and medius tendons that may be giving the greater trochanteric sort of pain syndrome. So I think we can probably do better with loading, and it would be interesting to compare this exercise group against the leap interventions, because I personally think they may be better loading exercises. We have then a variety of exercises that we might use for insertional, so proximal hamstring tendinopathy, insertional hamstring tendinopathy, where we're loading the hamstring whilst trying to avoid compressing it at the same time. And the compression comes in this particular image down here, where the person does a trunk lean. As the trunk goes forwards, the hamstring tendon here gets squashed against the ischial tuberosity, causing the compression in this instance. And that would be a later exercise that might be used. And this image comes from Tom Goom's paper in JOSP, Journal of Sports Physical Therapy. It seems to have hidden the reference there, so I do apologise for that. However, my preference is actually to put the biggest load we can through the hamstring, and in many respects we may as well just use simple Nordic hamstring exercises to do so, because if we maintain the trunk position in a straight line, we're not getting any compression of the proximal tendon anyway. So if we use Nordics, it's great, but we sometimes require a person to hold the patient's legs. There are ways of sort of coming up with a strategy at home, but if there's not, what we can do is use TheraBand exercises like this, or unloaded to start with, because we're not getting any compression here at this point. And we could bring on some compression if we want to in later stages by getting the person to do a trunk lean and lean forwards. And we can use some supported Nordics that we can see down here. And some isolated hamstring exercises in the gym as well, with a little bit of compression going on, but not too much because of the trunk position. These exercises are better than seated hamstring curls, where you're sat on the tendon at the same time as you're asking the muscle to pull. So you're ending up with tensile load and compressive loads at the same time, and that seems to be quite provocative for a lot of patients. Doesn't mean we don't do it, but it just means we're cautious with it in the early phases of rehabilitation. And Tom's work, Tom Goom's work within their paper has got some further progressions that you might use to start to do sort of hamstring load, tensile load, whilst you're getting some compressive activities. And this maybe allows all functions of the hamstring to be rehabilitated. The knee flexure activity it does, the hip extensor components, as well as some of the trunk control components that it does. So it's a nice method, but that's not been tested within available studies at the moment, because many of us don't see enough proximal hamstring tendinopathies to actually complete a meaningful research project on. When it comes to patellar tendons, there's a whole variety of literature out there on different exercises. We know that heavy, slow loading, these three, has been compared to eccentric loading, this one, and showed that the heavy, slow loading seemed to be a little bit better. It's worth pointing out this test was developed initially as a way of testing for patellar tendinopathy, not as a rehabilitation intervention, but many people have used it as a rehabilitation intervention. It's highly provocative as a test, and adherence often in studies is a bit worse when we compare it to other interventions like heavy, slow loading. Whilst it was better to use these three, I sometimes think, well, it's nearly a bit of a problem when you're giving a very provocative exercise and expecting patients to persevere with it. And there's a couple of other studies just to have a little look at these references here, looking at what, so systematic reviews or isometric interventions for patellar tendinopathy. And that was really popularised by some work from Australia that we'll come to in a moment. So we can do isometric work on sort of a variety of kit, or we can do isotonic work on these same pieces of kit. And I don't think it really matters that much what we do. Now, the isometric work was popularized by Ebony Rio, who did a seminal paper on this, looking at immediate analgesic responses as a consequence of doing isometric exercises. And the isometric exercises were done using sort of this type of setup. I thank the knee resource for allowing me to use these images as well. Because not everybody has the specialist kit, you can do like a Spanish squat using a seatbelt in a similar manner as well to what's been shown there. Now, interestingly, it looks quite positive as a benefit, but later studies have shown that it doesn't seem to be as good as the initial studies were suggesting. So just worth considering how effective it may be in the clinic. When it comes to the Achilles, what we know at this moment in time is it doesn't appear to matter what we do. We can do heavy, slow resistance versus eccentric is the same. Okay, Karen Silbernagel's approach of progressive loading seems to be very similar to eccentrics. So basically, all of these three studies, or three different approaches, seem to offer very similar results. However, if you look at the data within some of these studies, particularly Bayer's heavy slow resistance versus eccentric study, you'll see that the heavy slow resistance group had slightly better outcomes on visa-A, better satisfaction, they adhered better, and they all had some structural changes within the tendon. So it may be that actually, well, if it was me with a tendinopathy, I'd prefer to be in that group than this group. But the study wasn't powered to show a difference of 6. So with bigger numbers, you'd have concluded there was a difference between the two cohorts. But to a patient, it's about what they can do, what will fit in with them, and what is applicable for them. So I don't think it really matters what approach we want to go for. It's about coming up with a strategy for the person to load. When it comes to the isometric data on patellar tendons, looking for immediate pain benefits, immediate analgesia, it really showed great results. Big drops down from sort of 7 out of 10 average down to 0 immediately, and stayed down for 45 minutes. It's worth pointing out, though, it's a small study on 6 subjects. 3 of them had unilateral pain, 3 had bilateral pain, and we're talking about jumping athletes, and they're a different entity potentially to all of the tendinopathy. And the patellar tendon particularly is very different to all of the tendinopathies. So the Achilles, when you get tendinopathy, becomes more pliable. The patellar tendon, when you get a tendinopathy, becomes less pliable, stiffer. So they're different, and the patellar tendon is different as well because it's a bone, tendon, bone, whereas all of the tendons are muscle, tendon, bone. So there may be some different mechanics when we talk about the patella as well. And we replicated that study using 70% maximum voluntary contractions as the first paper had done for the Achilles, and we didn't show any meaningful benefit in either changes in strength, okay, or changes in pain during an activity. Actually, some people got a lot worse. These top 3 got worse. Some people dropped by 1, this person here, but 1's not a meaningful change on a numerical rating scale as far as we're aware. And if we looked at pressure sensitivity of pain in the Achilles, some people got less sensitive, so you could push harder for the same degree of pain. Some people got more sensitive. So it's a very individualized response to using isometrics, and I think we just need to not look at it as a panacea. We can consider it as a possible intervention to use, but it is not going to work with all tendons. And the various studies that have now been done on the plantar fascia and the recreation study on the patellar tendon have supported our findings, really, that is an individualized response. Some people it may be useful for, some it won't. So by all means try it, but do not avoid doing proven therapy during that time period. So have a little read of that paper if you want to. It's an open access paper, and it'll tell you a bit more about it. So We've got loading for plantar fascia, where we're using the windlass mechanism. So as the toe extends, that will shorten the plantar fascia, creating more load. And that seems to be useful in a preliminary paper, but again, we need some further studies to look at it and move it forwards. But it does suggest that maybe we're looking at a good outcome with them all. And Henrik Riel has done some fantastic work recently in Denmark, and one of his recent studies compared sort of isometric and isotonic exercise and walking for examining immediate pain benefit or immediate pain responses for people with plantar fascia. And he essentially found they all were equal. So sometimes people got benefit, sometimes they didn't. So it doesn't really matter what we do. That's what I'm telling you. That's what all the studies seem to be coming up with, particularly for isometrics. When we consider isometrics, though, it's not just about immediate pain benefit that we're really talking about. We should be looking about, actually, we're putting stress through tissue that people are fearful of loading. And this can prove to them sometimes that it's not hurting them, that it is safe to put that stress through there. It will also improve the tendon stiffness because we can put large stressors through using isometrics, often more than their body weight. And this will adapt the tendon, and this is part of what we want to do. But it will also alter the motor control of the person as well. We can target where they're weak and try and improve their strength. So it offers a meaningful way of doing or benefiting patients, but it's not the be-all and end-all. And if we are going to load the tendon using isometrics and we want to adapt the tendon, we need high stressors. 90% of your maximum voluntary contraction, according to systematic reviews on the subject. Importantly, you must note that this is only being completed on healthy tendons at this moment in time, and whether the same responses occur for diseased tendons is a different entity. And again, what all of the experts in the field are suggesting as being an appropriate strategy is progressive loading using something along these lines. Now, personally, I don't think we need to use isometrics necessarily. It's not an essential step. We can go straight in here for many of our patients and progress up the spectrum. But we've got to look at, well, they need to do this. They're currently here. We've got to bridge that gap. And that's what we're always talking about, I think. So bridging that gap is the important bit. And the later aspects are plyometrics and speed work. Okay. Again, the specific exercise that is used, I do not think matters. It is about this progression. The problem we see with this progression is we have our injury occurring up here, okay? We then go through, we're trying to get back down to this stage where we can return to play. The problem is how we're getting there. People will go through this, but often it ends up as a bit too fast and causes breakdown, okay? So why does treatment work? It's an important consideration because all of those treatments work. The studies have all got good support. Loading is a good intervention. But why? Well, in the etiology section, we talked about how this changes in the structure of the tendon. And we know that this load-based intervention may well change these things. But is it important to always change those things? And can we change it? There's a current theory from the Australian group with Jill Cook that the tendon is like a donut with a hole. The hole is the degenerative zone. And actually, the hole cannot change. But maybe the donut can grow. The healthy tissue can adapt. And that sounds quite plausible. But we just have to be careful because the study that it's based on was a cohort study where they looked at people at one point of time with changes or without changes in the tendon. They didn't follow people up for a long period of time to see if the whole actually got better. And what we interestingly know from some studies that have been done where in this instance they scraped the tendon, so they didn't go inside the tendon and also remove plantaris, is we can clearly see that this area of red, this degenerative zone on a UTC scan, gets better within a 6-month period, suggesting that tendons do remodel and the hole does go. And we also know from healthy data that tendons can clearly adapt here. Okay, so I think the hole can get better. I do not think the whole necessarily needs to get better for the person to improve, and we certainly shouldn't be focusing on structure, but it can improve. And for athletic individuals, it is probably important we do our best to get rid of that hole, because that is our biggest known risk factor for developing tendinopathy during the subsequent season. In the past, people have sort of tried to come up with why treatment works, and all of these sort of factors have been discussed. I've got a paper that discusses them all. If you want to have a read of it, it will go through them in far more detail than we can on here. But essentially, they've all been shown to be flawed, with the red ones being where the current sort of thinking is going. Now, we'll discuss each of these in turn, okay? So, central sensitization. Well, the problem for lower limb tendinopathy is, according to papers that are currently published that are referenced on here, is no. There is not central sensitization when it comes to lower limb tendinopathy that have been measured at the moment. And by that, I mean the Achilles and patella. GTPS, probably yes, it does have it. But if there isn't central sensitization, well, we probably can't look at intervening for those aspects. And the most widely used measure of central sensitization is widespread secondary sensitization. So this is where other areas of the body become sensitive. Interestingly, with one study which you need to be aware of, this TOMPRA study, they looked at submersion of a hand into water, not the whole body, and measuring pressure thresholds on the Achilles tendon in a group of people with tendinopathy and a group of people without tendinopathy. After submersion in cold water, we become more sensitive on our Achilles tendon if we're healthy. The people with tendinopathy got more sensitive with the immersion, but not to the same level as the healthy people. So, what does that mean? It's something I would challenge you to go and read this paper, British Journal of Sports Medicine, and consider what it means to you and your patients. Submersion into cold water makes you more sensitive, but if you've got tendinopathy, you get less of a response, less sensitive. So, rather than a secondary change as a consequence of tendinopathy, that could be something the person had before and actually led to the tendinopathy, because they're less aware of pain. They get a less exaggerated pain response when they get a painful stimulus, cold water immersion. So maybe if you're a runner who has that trait, as you run, your body or your brain doesn't process the sensitivity that you're getting from the tendon. So you keep running, causing your tendinopathy. Maybe. It's one of those things. Have a think. I'm never sure how it relates to my patients and whether it influences my treatment. Neuromuscular is next down on the list. Now, there is robust evidence for alterations in neuromuscular sort of function. A little bit of a suggestion from patella that there may be increased inhibition, but when it comes to the Achilles, there's certainly increased excitation. People working at higher levels of their maximum EMG, changes in H reflexes and a variety of other aspects, variety of alterations in strength profiles, endurance profiles, and muscular contraction methods where the tendon's been observed to oscillate, so it's shaking, which I'll show you some videos of in a moment. And some of these studies have been done prospectively before the development of tendon disorders, suggesting that they are the chicken that lays the egg, as opposed to something that occurs after tendinopathies occurred. And for further evidence, have a read of the paper that discusses all these mechanisms from myself, open access, and also Pete Malieras' systematic review here. The conclusion of Pete's review was that essentially the neuromuscular performance elements are potentially the best rationale for why people get better with rehabilitation. And they've shown evidence for that, and in the paper that I published, we were looking at why that might have been the case. And we've suggested it may be because there's differences in neuromuscular contraction. So in this study by Jonathan Rees with heel raisers, what he observed was there's two groups. They're roughly the same body weight, 70 kilos was pretty much the average for these army recruits. But some people were low loaders during the heel raise. So they got sort of twice body weight as an output. That's this blue group down here. The red group actually were around about 4 times body weight was the stress through their Achilles tendon during that activity. And the only logical explanation for this is a biomechanical or neuromuscular alteration. So it may be longer levers, tibial length and foot length, or it may be alterations in how the muscles were functioning, or combinations of those two aspects. And what Jonathan also showed in their study was increase in oscillations of the tendon when the tendon's vibrating. And this has been shown by other people, Henriksen and Grigg as well, where they've sort of talked about a specific frequency of between 8 and 12 hertz, so 8 or 12 vibrations per second. And vibrations of a tendon or a muscle at that type of level is basically indicating a physiological muscle tremor. So the muscle is shaking as it's lengthening, and it occurs during primarily eccentric contractions rather than concentric contractions, as you can see on this chart if you look at it, suggesting that eccentrically the body or the brain isn't able to coordinate the contraction, so the muscle tremors. But this is only observable, or much more markedly observable, in people with tendinopathy. Now, we observed the same thing during our isokinetic testing, where we have smooth control patients here, where it's a nice smooth one, versus our patients who are oscillating as they do a contraction. And what this means is during an eccentric contraction, the muscle should be smooth, but the muscle is stopping and moving again, and it's juddering as a consequence of this discoordinated contraction. Every time it stops, the tendon will undergo a mini stretch shorten cycle, and that repeats frequently each repetition. I personally, at this moment in time, think that is the mechanism by which rehabilitation works, as opposed to the mechanism by which we're improving the tendon. It's about changing the neuromuscular pattern. Now, to show what that can sometimes look like on a isokinetic trace, we have concentric on the left, eccentric on the right, healthy person at the bottom, injured Premiership footballer at the top. And what we can observe is alterations in the traces that you're observing, particularly eccentrically here. This eccentric contraction, the person's sort of flatlining. They're not able to generate force between 5 and 20 degrees of plantar flexion. So we went from around about 20 degrees of dorsiflexion to 30 degrees of plantar flexion, and they're nearly generating nothing during that particular position. The peak force is down compared to the healthy person below, but most importantly, the tracers have a very different sort of shape. So if you have the ability to ever look at it, examine it using some kit like that. But what we'd observe as we see these tremors in action, you'll see the person's shorts move. It's easier to see in the flesh than it is often via videotape, but you can see during the movement down, it's not smooth. The person's actually having a little bit of a problem during that activity. We should be able to see the same again as we go through here. So that's it. So the muscle's tremoring during that lower. Okay. Now, I personally think we're trying to do our rehab to stop that happening. That's really where we're trying to intervene. That's what we want to be seen to change. So how we go about our rehabilitation is to get patients to do a stop-start contraction during this activity. So instead of coming all the way down, just doing a normal rep, we'll get them to stop at 25% down, then go to 50%, then go back to 25, then come to 75, back to 50, back to the top, all the way down to the bottom. So it's much more neurally demanding task than a simple rep. Because how many times do you see a patient do an eccentric lower and they'll just drop straight down? they don't actually control it. There's no neural demand. There's very little muscular activity. It's sometimes just a drop. And if they do a controlled drop, it's quite quick at their preferred speed. It doesn't involve a stop-start, which develops much more neural change, which will change the person's strength in a much more meaningful way. So a bit later on this video, you'll get the voiceover from me.
Go back up a bit, hold it there, back up a bit higher, hold it there, up all the way, hold it, come down halfway, hold, down all the way, right the way to the top.
So that's essentially how we're going about our rehabilitation. And you'll find that your patients will get much more muscular ache as a consequence of this, because it's a much more demanding activity. And we can alter the foot positions, the knee angles, to really try and isolate out which muscle we're targeting, and to put more stress through the different zones of the tendon where we've probably got the biggest tendinopathic lesions or changes. So that's really what we're after. And that weak, discoordinated muscle, we think, will actually lead to the tendon having more hysteresis. That's energy absorption during an energy storage phase. So we think that people start to get increased heat. And this has been reported in the etiology studies, where heat shock proteins are part of the chemical cascade of tendinopathy. And these chemicals trigger the tendon cells, the tenocytes off, making them become irritated and actually causing an overly amplified reaction that leads to changes in the tendon. Equally, if the stretch shorten cycles are repetitive, like we've just shown you, then we think that increases the stress on the tendon, also triggering the change. So forgetting about heat, it's just stress on the tendon cell. That reacts the cell, makes it do the wrong thing, produce the wrong chemicals, those GAGs, glucosamines and chondroitin, proteoglycans that we talked about in the etiology section. And that sets up this cellular cascade to tendinopathy. And our rehabilitation can take these poorly coordinated people and tip them into a better coordinated muscle activity pattern that reduces the stress on the tendon, improving energy absorbency, but most importantly, getting the muscle to protect the tendon, to act as a shock absorber. Have a read of the article, please, because it explains it a little bit more than I'll have time for within this. So the literature related to neuromotor changes is robust. There is a lot of literature supporting this, and it's the best explanation we have at this moment in time. However, we've always got to come back to remembering the person. Okay, so fear avoidance, catastrophizing thoughts, pain behaviors we talked about earlier. And one of the best examples, or worst example if we look at it properly, I have of this was a young 28-year-old fit and active male patient who was put in touch with me through social media, who'd been told by a leading foot and ankle surgeon in the UK that they had a tendon of an 8-year-old and they needed surgery to strengthen that tendon because otherwise they were going to snap their Achilles tendon, and that they should take their flexor hallucis longus and stitch it through the Achilles tendon in order to make it more robust. I asked them to send down the imaging that they'd had done, which was an MRI scan, and the MRI scan showed a very mild tendinopathy of their Achilles, and this person had not undergone any rehabilitation at this point and was listed for surgery. And that will obviously, receiving that information as a patient, you will just go, oh, that is shocking. This is what I need to do. And understandably, that's what the lad in question was going to go and have done. But actually, just with a bit of reassurance and explanation that the scan was quite mild, this is the other thing, sorry, I forgot to say, he'd also been told he'd got a very rare condition, something that we might not have heard of, and that rare condition was Achilles tendinopathy. Bearing in mind it might affect up to nearly 60% of runners during their running lifetime, it is not a rare condition, and to say such is misleading to patients, leading them to have different expectations and thoughts about what they should be having done. And this young lad did superbly well with just some, I think it's about 4 weeks of simple eccentric rehabilitation. Not because I think eccentrics were best, it was just part of a project I was running at the time. We had some online training that he could look at the videos and use. And he did really well, and obviously didn't go on to have surgery. But that is something we have to unpick. And if we don't ask our patients about these catastrophic thoughts, we don't get to hear about them, and we can't unpick them. And if we can't unpick them and change them, we cannot get the patient to buy in and do the right things that will ultimately make them better. Because that chap needed to change his loading, both what he'd done historically, but also improving the neuromuscular components of the tendon. So it's important to consider, and using the Tampa scale of kinesthesiophobia to actually examine this is useful. So in a nutshell, what we're trying to do is modify our load, change the worry and the fear for the patients, improve the muscle tendon unit function, whatever exercises we want to do that. Ensure there's sufficient time, okay? Time is important here for tissue adaptation. A review that came out this week has shown that actually tendon changes may be linked to time more than the intervention itself. So we will modify load. We will change that loading. We will progressively load the person's body in a way that will adapt the muscle tendon unit function and the tendon structure in the long term. But we will do that encompassing the person as a whole to reduce their fear, reduce their avoidant behavior, and reduce their catastrophic thoughts that they're having. And we must seek to ask them about what they think's wrong, why they think it's happened, and what they should do with it, because that will help us understand some of these fears and thoughts that the patient is having. So I think at this moment in time, as I talk to you now, and it may be different in a year or two's time, neuromuscular changes are probably the most critical mechanism, but that may alter. Thanks very much for listening again, and we'll see you in future podcasts or webinars. Cheers, guys.